Hi everyone, this video is about assessing for suicide and self-injurious behaviors. We'll begin with the suicide assessment and intervention, and we'll be utilizing the SAFET acronym, which has been developed by the Education Development Center Incorporated and the Screening for Mental Health Incorporated. So SAFET is an acronym that provides a helpful way to remember the steps of evaluation, and we'll be going through each of the 5 steps one by one. So beginning with identifying risk factors, moving on to identifying protective factors, conducting a suicide inquiry, determining risk level, and documentation. So first, identify risk factors. So this essentially involves assessing for conditions that may increase the level of risk for this particular client. The first thing to keep in mind is suicidal behavior. Any history of prior suicide attempts, aborted suicide attempts, or self-injurious behaviors may be a heightened risk factor for clients. So we should assess to find out whether or not they have any history of suicidal behavior. We also want to keep in mind that the presence of a current or past psychiatric disorder, especially mood disorders, psychotic disorders, and PTSD, are also risk factors for suicide. Then we want to keep in mind key symptoms. Some symptoms to watch out for are anhedonia, hopelessness, impulsivity, and command hallucinations. The presence of any of those symptoms indicates a heightened risk for suicide. Next is stress. Specific triggering events that lead to feelings of shame, humiliation, or despair can be problematic and increase risk. So an example would be the loss of a relationship, loss of some kind of status like losing a job, and deaths can also be stressful. This can also include medical illnesses like chronic pain issues or terminal diagnoses. It can include family turmoil or chaos, history of abuse, and I've already mentioned recent death. Next is change in treatment. So a client who's recently been discharged from a psychiatric hospital, for example, or who has lost their provider or their therapist for some reason, is at heightened risk. The last two, access to firearms and demographics, should also be kept in mind. So access to firearms is fairly obvious, and for demographics, there are certain social groups that are at a higher risk for attempting suicide, and these include males, adolescents, individuals over the age of 65, and individuals who have been divorced. Once we've assessed for the presence of any risk factors, we want to move on to assess for preventative or protective factors. This can be helpful because it can help to offset some of the acute risk factors. Do note, however, that even though they are present, they might not counteract significant acute risk. So this doesn't mean that a client who has some or all of these protective factors won't attempt suicide. So we split protective factors into internal or external. Internal includes the presence of coping skills, like someone who does yoga or meditation or exercises. Those would be coping skills. Some religious beliefs may be protective. For example, if a person believes that suicide is a sin, this may be protective in that it would prevent them from attempting. This is asterisked, however, because in some cases, religious beliefs can be a risk factor. So, for example, if someone believes that they're being punished by God, this can become a risk factor as opposed to a protective factor. Next, frustration tolerance. So having a high frustration tolerance may help offset some risks. And then finally, having a future orientation, meaning that they're looking forward or ahead to something, even if it's only a little into the future. For example, if they're looking forward to a birthday party that they're supposed to attend next week. This is still a future orientation and may help offset some risk. Next, we have external protective factors. These are things outside of the individual that can help to be protective. So first, feeling a sense of responsibility to a loved one, such as a family member, a child, parents, or beloved pets can be protective. Also, having a positive therapeutic relationship with you can be protective because they trust you and they may be more likely to reach out to you in the event of a crisis. And then finally, having social support. And this can be through friends, a partner, a support group, a church group, and so on, if the client feels that they are supportive. Once we've identified risk factors and protective factors, we would then do a suicide inquiry. And this involves specific questioning about thoughts, plans, behaviors, and intent. This is typically what we think about when we think of suicide assessment, but it's important not to jump to this before we've assessed for risk and protective factors. This helps to give us a more complete picture of the client's risk. So for ideation, we're talking about thoughts about killing oneself or persistent thoughts of death or dying. We want to assess for present ideations, ideations in the past month, and the worst ever ideations. Once you've done this, you would assess for intent. This means the extent to which a client plans to kill themselves and beliefs about the planning being lethal. So how lethal do they think their plan is? Okay, and so an example would be someone who says, I want to kill myself to end this pain, would be more indicative of intent that has moved on from just thinking about death or dying to actually wanting to kill the self. Once you've assessed for intent, you would move on to assess for a plan and means, which is a specific method that the client has thought of to use to kill themselves and their access to that method. In this case, we want to assess for timing, location, lethality, availability, and preparatory acts. For lethality, we're interested both in the imminency and in the actual risk of death from the plan. Someone who says they want to kill themselves next month has a lower risk than someone who says they plan to kill themselves when they leave your office. This doesn't mean that we ignore the risk. It just helps us to gauge how imminent the risk is. Similarly, someone who plans to kill themselves by starving themselves compared to someone who plans to run into traffic. Those are very different risk levels. Please note that regardless of lethality, you should take all threats of suicide seriously and be sensitive to the emotions the client is experiencing at this moment that have made it an option. We must take all threats seriously. For availability, we're looking at access to the components of the plan. For example, if they plan to shoot themselves, do they have access to a weapon? If so, this heightens risk. Have they maybe started to look into how to get a weapon? This also heightens risk if they don't already have one. And this is different from someone who has no idea how to go about accessing a firearm. If the client is planning to overdose, do they have prescription medication they can use? Or have they been stockpiling over-the-counter medication? Do they have knowledge about how much Advil to take, for example? Those things heighten risk. Again, availability increases risk. Finally, for preparatory acts, we're looking at rehearsals such as tying a noose, loading a gun, etc., writing a suicide letter or a suicide note, selling off possessions, quitting a job, or creating closure in other ways, such as saying goodbye to people. Those are all things that would increase risk and are associated with assessing for plans and means. Now, when you're doing your suicide inquiry, you may choose to utilize a screening measure to help you, either by having the client fill it out on their own or by using it as a guide for questioning, which is what I personally would recommend. I am of the mindset that discussing it is going to give you a better assessment of the risk than having someone fill it out on their own, like in a self-report measure, which may make them feel a little more guarded or make them be a little less honest. So here's a list of various suicide assessment measures, and they can each provide you with information about risk for suicide. But remember that no instrument can predict whether, when, and how a client may attempt suicide. So these are not a replacement for your clinical judgment and your own assessment. One potential measure is the Beck Suicide Scale, or the Beck Scale for Suicidal Ideation. The questions here are written in a way that ranges from 0, being low to no risk, and to 2, being high risk. For example, in the one that's written here, it says 0 would be, I have brief periods of thinking about killing myself, which pass quickly, which would be a lower risk than 1, which is I have periods of thinking about killing myself, which last for moderate amounts of time, which is still lower than 2, which is I have long periods of thinking about killing myself. There are other questions in this measure about suicide attempts, intent, and so on. And you could easily modify this questionnaire to be used as an assessment prompt. For example, with this question, you could ask instead, tell me how often you think about killing yourself. And then you could follow up with, how long do these thoughts normally last? So in this way, you can convert a self-report measure into an assessment tool that you use in a clinical interview to assess for suicide. And the same is true for any of these. Once you've done steps 1 through 3, you can then determine what the risk level is and intervene appropriately for this particular client. Your determination of the risk level should be based upon the results of your assessment, your clinical judgment, and the specific client characteristics, meaning the risk and protective factors that you've identified already. The type of intervention you select in this case should then be dependent on the level of risk you've assessed. Remember that you're legally allowed but not mandated to breach confidentiality in cases of danger to self. How much you breach and whether or not you breach exists on a continuum and is based on how high or intense the risk is. You want to select the least restrictive option whenever possible, but you must always take into account how high the risk is. A range of risk levels and interventions is provided here in the infographic I've presented on the slide. And this is from a pamphlet that was created by the Education Development Center and Screening for Mental Health, Inc. Remember that this is not a replacement for your clinical judgment, but it does help to provide a bit of a guide in terms of how intensive your intervention might be at certain levels of risk. So with a lower risk, we're looking at intervening by attempting to reduce symptoms through coping skills building, crisis planning, and provision of emergency numbers and supports. Then at a mid-range or moderate level, we're going to introduce more intensive safety planning, perhaps activate the client's social support network by contacting their emergency contact if they give you permission. Potentially taking steps to remove means, assuming that they have them. So maybe asking the support person to secure the firearms or to secure the medications. And perhaps we're beginning to consider hospital admission at this point if we feel that the risk is high enough, even at this moderate level. And of course, we're always going to attempt voluntary hospitalization first. At high risk, we are definitely pursuing hospitalization. Remember that involuntary hospitalization is the most extreme intervention because it involves taking a client's rights away. So only select this if the client is unwilling to do anything else and the risk is high. Once you've intervened appropriately, you must not forget to document everything. This includes documenting the risk level you identified and your rationale for that risk level. This documentation serves to protect you. Your treatment plan or intervention that were used to address the risk level should also be included in your documentation, as should any follow-up plans that you've developed, including phone check-ins, follow-up sessions, referrals, and so on. And if the client is a minor, the roles that you've assigned to the parents or guardians, and how those are there to assist with offsetting the risk. This documentation will go in your client's chart. Okay, so now I'm going to walk you through completing the suicide assessment section of the DMH assessment, which is section 2. Okay, so this here is section 2 of the assessment, which is right beneath the presenting problem on the first page, and is fairly self-explanatory in that it's a bunch of check marks or check boxes and follow-up comments. Okay, so first, number 1 is asking, has the person wished they were dead? And you would check off yes or no. This is looking at thoughts about death. Okay, obvious. Next, within the past 30 days, have they actually thought of killing themselves? You would check off yes or no. This is getting at ideation. If the answer is no here, you would skip to question 6. If it's yes, you're going to continue on to number 3. So here in number 3, we're asking, has the person been thinking about how they might kill themselves? And this is getting at a plan, and you would check yes or no. Next, you would screen for intent in question 4 by checking yes or no. Now, in the second part, we're looking at more specifics about the plan, specifically accessibility and means. Okay, so yes or no here. Finally, in number 6, has the person started to take steps toward carrying out the plan? And you would check off yes or no. If yes, you would elaborate by explaining how long ago they did this. You'll notice at the bottom that there's space for additional comments, and this is where you could include any further details about your assessment. If any of the boxes in questions 1 through 6 are checked off yes, you absolutely need to have more comments here elaborating on those yeses and indicating that you have assessed this thoroughly. Okay, a related issue here is self-injurious behaviors, also known as self-harming behaviors. And this question is directly below the suicide assessment questions. as you can see here. So self-injurious behaviors include any behaviors that are self-inflicted and harm the body. So things like burning, cutting, or starving oneself, and there are plenty others. If the client endorses self-injurious behavior, you would then assess method, frequency, severity, and purpose. Okay, so method, how are they doing it? Frequency, how often are they doing it? Severity, how severe is it? Is it requiring medical treatment? Okay, and purpose. Don't overlook purpose because people engage in self-injurious behaviors for lots of different reasons. Some to cope, some to feel pain, some to numb, and so on. And if you're planning to address their self-injurious behaviors therapeutically, you'll need to introduce a replacement behavior. And that replacement behavior is only going to be effective if you know the purpose of the self-injurious behavior so that you can replace it effectively. Okay. The mental health history section is what we will do next. And this is section 3 of the DMH assessment. And in this section, we're assessing for previous mental health treatment history, homicidal ideation, and trauma exposure. We'll begin here with psychiatric hospitalizations, and it is assessing for previous history of hospitalizations, both voluntary and involuntary. You can also include partial hospitalization here if a client has done that. You would assess for this section simply by asking the client to tell you about any history of hospitalizations for mental health reasons. Some clients may get confused here and will give you medical hospitalizations, but unless these medical hospitalizations are the result of a mental health issue, such as someone who's someone who's hospitalized due to an overdose, these are not included in this section. So for each reported instance of psychiatric hospitalization, you'll want to gather information about the dates of treatment, so beginning of treatment to end of treatment, location, meaning which hospital, reason for hospitalization, why were they hospitalized, and whether the hospitalization was voluntary or involuntary. Once you've gathered this information, I strongly recommend you follow up by asking what they found helpful and not helpful about each experience. This can help to guide you in selecting interventions for the client in the future. Finally, it can be helpful to ask the client about what happened once they were discharged from the hospital. Were they linked to services, for example? And if so, did they follow through with them? I've written an example here in italics and highlighted the components that I listed above. So first you can see I have how long they were hospitalized, 7 days, and when, in September of 2016, and why they were hospitalized, attempted suicide by overdose. I've also indicated that it was a voluntary hospitalization, and I provided information about what happened when they were discharged. In this case, the client says that they felt better, so they did not follow up with the referrals that they were given for outpatient treatment. And then I asked what made the hospitalization helpful versus not helpful. And the client says that they found group therapy to be helpful and finding the right medication by working with a psychiatrist was helpful. So this is useful information for me because I may then provide a referral for group therapy as I work with the client and also make sure that they've been checking in with their psychiatrist for their medication reasons. Next in this section is the outpatient treatment section, which is the client's previous history with therapy on an outpatient basis. Similar to the psychiatric hospitalizations, you can elicit this information simply by asking the client to tell you about their previous experience in therapy. If they have had previous experience, you would need to provide information about the type of therapy. Was it individual, family, group, etc.? The dates of treatment, beginning date, end date, or an estimate if they have it. If they can't give you dates, an estimate of how long they were in therapy. The reason for treatment, is it the same as why they're coming to you now, different reason? And why treatment was stopped. Did they meet their goals? Did they quit? Did they not like their therapist? Whatever. As with the previous section, I recommend asking what they found helpful and not helpful in therapy. This can guide you in your own therapy with them. And if the client says that they have not had any previous experience, it can be helpful to ask why not. This can give you some information about potential stigmas, beliefs about therapy, and barriers to therapy. I provided an example here. This client did not have former therapy experience and explains that now they want it because they have a different motivation to be in therapy. Okay, In the next piece of this section, you're completing a homicide assessment, meaning that you're assessing whether the client has current or past thoughts of harming another person. The acronym ACTION provides helpful areas to screen for homicide risk. A stands for attitudes. Does the client believe that violence is justified in certain situations? Included in this is figuring out whether the client has a past history of violence. Someone with attitudes accepting of violence and past violent behaviors is a higher risk. C is capacity. Does the client have the means to carry out these threats? This would be similar to assessing for means in suicide ideation. T is thresholds crossed. Does the client have a plan, and what is the extent to which they've started to put the plan into place? This is similar to assessing for a plan or means for suicide. And someone who started to gather things to carry out their threat, of course, is a higher risk. For example, someone who's purchased a gun. I is intent. Does the client have a serious intent to harm others? This one's fairly clear. However, remember that with our terrorist off-duty, we are looking for imminent risk to physically harm another person. We're not including things like property damage when it comes to our duty for terrorist off. O is others' reactions. Have others encouraged or discouraged the hostile behavior? If others are encouraging it, this heightens the risk. And N is non-compliance. Is the client unwilling to consider alternatives to violence? Of course, non-compliance is a huge risk factor. Once you've completed your assessment and identified the level of risk, you should intervene appropriately, just like you did for suicide. In cases of moderate to high risk, this may involve your duty to protect, which would require contacting local law enforcement to inform them of the threat. After you've intervened, be sure to document accordingly, just like you did for suicide. Finally, in the last piece of this section, we are assessing for trauma exposure, and DMH wants you to assess specifically for the 7 areas cited. This means that you must assess for each of these and indicate your assessment below. You should not write, client denies any history of trauma exposure, because this makes it seem like you didn't assess these areas. You can either ask about these areas directly, or you can use a trauma assessment tool, such as the Brief Trauma Questionnaire or PTSD checklist. Any endorsement of trauma must include a few details about the event and the client's coping with it. Don't overdo your assessment though, because you don't want to re-traumatize the client or open up a box that you won't be able to close in the time period of your assessment. So you can see in my example that I've indicated where there is violence that the client or trauma that the client has experienced. And I've also indicated the parts that were denied in the last sentence. Client denied any history of sexual assault, living through disaster, and so on and so on. So please do make sure to indicate that you've assessed for all 7 areas in this section, even if that is just listing off the ones that the client denied. If the client has endorsed certain experiences of trauma, elaborate briefly, only as much as necessary to complete the assessment. So that is it for this section. Let me know if you have any questions. Thank you.